Bismillahirrahmanirrahim. Assalamu alaikum. This week's lecture is about secondary amenorrhea. If you remember from last week's lecture, amenorrhea could be divided into primary amenorrhea or secondary amenorrhea. In order to have a regular menstrual cycle, there should be an intact hypothalamic pituitary ovarian axis. A defect at any of these levels may lead to cessation of the menstrual cycle. It could be defined as the cessation of menstruation for 6 consecutive months in a lady who has had previous regular menstrual cycles. Some may consider 3 or 4 months of amenorrhea to be pathological and may define it as secondary amenorrhea, but there will be a confusion with oligomenorrhea. It is best classified according to the origin, or if it is due to a generalized systemic disease affecting any part of the axis. How do we manage cases? We will take secondary amenorrhea according to the level of defect, and at the same time, there will be mentioning of the management of cases briefly. First of all, if a patient complains from loss of menstrual cycle for more than 6 months, the patient should be sent for a beta-HCG pregnancy test to confirm or exclude pregnancy, among the other investigations that the patient is sent for. If we come to genital tract abnormalities, the problem could be in the uterus or in the cervix. Sometimes, following vigorous curettage to the endometrium, whether it is a diagnostic curettage or following an incomplete abortion to evacuate the retained pieces of conception, there will be curating of the basalis layer of the endometrium, resulting in adhesions or synecdoche within the endometrial cavity, a syndrome which is known as Asherman syndrome. Sometimes the adhesion involves all the endometrial cavity, so the patient is totally amenorrheic, or partly, so she will have a change in the menstrual cycle in that it is scarce. The blood loss will be less than before. The intrauterine adhesions could be seen on hysterosalpingogram. Alternatively, a hysteroscopy could be used for diagnosis and at the same time diagnose and treat policy at the same session. The adhesions, as I mentioned, can involve the anterior and posterior wall. It may contain vessels, muscle, and endometrium. If we remove them, we will try to use measures in order to prevent the re-adhesion, either by prescribing the patient estrogens or combined estrogen-progesterone, or inserting a Foley catheter in the endometrial cavity or intrauterine device. A second look hysteroscopy or hysterosalpingogram may be required within several months. As you can see, here is a normal uterine cavity, like an inverted triangle on hysterosalpingogram, and this image shows a normal cornu where we find the openings of the tubes through hysteroscopy. However, in these images, hysteroscopic images, you can see that there are adhesions within the endometrial cavity. The adhesions could be slight or extensive. Here you can see the filling defects within the endometrial cavity because of these adhesions. As a summary, the diagnosis is by hysterosalpingogram or hysteroscopy, and treatment is by adhesiolysis of these synecdoche. The other anatomical problem could be due to cervical stenosis, which can be an occasional cause of secondary amenorrhea. It may be following a cone biopsy for the treatment of CIN2 or 3 However, the modern procedures have less such complications. It may follow also vigorous curettage resulting into damage of the cervix, sometimes following repeated procedures for cervical circulage or cauterization of the cervix may lead to fibrosis and stenosis. Treatment consists of careful cervical dilatation under ultrasound guidance to avoid creating fold passages through the cervix. Here you can see a stenoid cervix where the os is so tiny. However, here is an image of a normal cervix. Ovarian causes of secondary amenorrhea may be divided into the polycystic ovary syndrome or premature ovarian insufficiency. The polycystic ovarian syndrome is a complex and a relatively common condition, even especially now with the changes in the lifestyle, where it's slightly more sedentary. Ladies are using cars more, the delivery services less. They are walking less, probably to work, probably to the market, and it has contributed significantly. Also due to changes in the eating habits, all of them have contributed to the increase in the incidence of polycystic ovary syndrome. Some studies suggest that it is familial with the autosomal dominant pattern. However, environmental factors, especially obesity and inactivity, poor dietary choices, all may exacerbate its occurrence. And sometimes it is just reversible with lifestyle modifications by losing weight and exercising more. The Rotterdam criteria for diagnosis of polycystic ovary syndrome: the patient may have 2 out of 3. She may complain of infrequent cycles or amenorrhea, biochemical and or clinical signs of hyperandrogenism, and polycystic ovaries through a transvaginal or abdominal ultrasound. The patients will have different symptoms, and accordingly we manage the patient according to her complaint. She may have just polycystic ovaries by ultrasound. She may complain of oligomenorrhea or amenorrhea. Her cycle comes every 3 months, every 6 months, and she wants a regular menstrual cycle. She may have infertility and request subfertility and request treatment in order to conceive. There may be pelvic pain, hirsutism, acne, male pattern baldness, acanthosis nigricans, and so we manage obesity. We manage the case according to the patient's presentation. Treatment, as I mentioned, should be individualized through lifestyle modification, losing weight, exercising more, the anti-diabetic metformin, which is very effective in improving the sensitivity of the ovaries to insulin, because there will be insulin resistance in cases of PCOS symptom patients. If she is infertile, we may go for ovulation induction policies, or we can treat menstrual disorders by giving her progesterone or combined oral contraceptives. And the patient may just want her hirsutism to be treated using cosmetic methods or sometimes drugs. As you can see, these are images of acanthosis nigricans. Here we can see the polycystic ovary where the follicles are arranged like a pearl necklace, or the other features of hirsutism, of polycystic ovary syndrome. The other ovarian cause of secondary amenorrhea is the premature ovarian failure, where it is defined as the cessation of menstrual cycles before the age of 40, associated with a rise in the level of FSH and LH or the gonadotrophin level. It can occur at any age. 70% of patients with primary amenorrhea have found chromosomal abnormalities have been found, while it has been found in only 2 to 5% of patients with secondary amenorrhea. It means it can contribute to the occurrence of secondary amenorrhea. And ovarian insufficiency before puberty is usually most likely due to a chromosomal abnormality, or if the child has been exposed to chemotherapy or radiotherapy due to a malignancy. The causes of secondary amenorrhea that may lead to premature ovarian insufficiency are autoimmune diseases. The patient may have an autoimmune disease where the autoantibodies affect the function of ovarian tissue, chromosomal abnormalities, as it has been mentioned, infections, previous surgery, chemo, and/or radiotherapy. Before this syndrome is quite interesting, which is known as the resistant ovary syndrome. The patient may have periods of amenorrhea with the sudden occurrence of cycles every several months, once per year, and still her FSH level is high. It could be due to a spontaneous ovulation, and sometimes they may even achieve a pregnancy during this period, usually in the late 30s or early 40s. And here, in cases of resistant ovary syndrome, we will find the presence of primordial follicles on ovarian biopsy. For women who are predicted or ovarian failure is anticipated in these ladies, for example, due to if she's going to be exposed to chemotherapy, we can do cryopreservation of the oocytes and use them later in IVF or in vitro fertilization protocols. And an alternative is the surgical removal of the whole ovary and transplantation of cryopreserved ovarian tissue once her therapy is over. And live births have been achieved by all these methods. If the lady has premature ovarian failure, then she is at risk of having all the complications that a lady may have after menopause. However, they will be more intense because of the longer duration of exposure to estrogen deficiency. So hormone replacement therapy is advisable to reduce the consequences of estrogen deficiency, especially osteoporosis and cardiovascular complications. So younger ladies have an increased risk of osteoporosis because, as I mentioned, of the longer duration of hypoestrogenism, and of course, it is worse in cases of primary amenorrhea. So early diagnosis and correction with estrogen replacement or hormone replacement therapy is advisable, and the cardiovascular protective effect of estrogens has been noticed through increasing the cardioprotective high density HDL and decreasing total cholesterol and LDL. So it is overall cardioprotective. At the same time, it reduces the incidence of dementia and stroke events, especially if it started early. And also it improves the quality of life for the patient. Some patients may request that they want to have menstrual cycles to feel their femininity. This is an understandable request, and it is worth treating. Pituitary causes of secondary amenorrhea can be categorized into Sheehan syndrome and hyperprolactinemia. Sheehan's syndrome usually results after a severe postpartum hemorrhage, where there will be necrosis necrosis of the pituitary gland, the anterior, posterior part, or all of the pituitary gland, because it has been enlarged during pregnancy, and thus any defect in the blood supply can lead to necrosis. The degree of severity of Sheehan syndrome will according to which part of the pituitary has necrosed. We may induce ovulation induction through they can achieve pregnancy, of course, because the ovaries is okay, through the gonadotrophin releasing hormone or human menopausal gonadotrophin. The acute presentation, the patient, after delivery, she finds that she cannot breastfeed the baby. She may complain of hypotension, tachycardia, and hypoglycemia. On the chronic point aside, she also still cannot breastfeed her baby. She will have loss of axillary pubic hair. Her cycles may be absent or scanty. Features of hypothyroidism and hypoadrenalism if that part of the pituitary is involved. And the second cause of pituitary causes of secondary amenorrhea is the hyperprolactinemia. Of course, not all patients will have visible galacturia. The prolactin level may be high, and without galactoria. There will be an elevation in the serum prolactin, sometimes due to stress, sometimes due to a recent physical or breast examination. It could be due to drugs taken by the ladies, such as carbamazepine or metoclopramide. However, it may be several hundreds. If it's over 1,000, we will think of tumors. And we repeat the test. If it's still high, we will think of tumors. We will send the patient for CT or MRI to check the pituitary fossa. Sometimes, if it is very high, we can find that it is due to a pituitary adenoma or a non-functioning disconnection tumor affecting the prolactin secretion. Other causes, hypothyroidism, may be associated with raised prolactin level, patients with polycystic ovary syndrome, and several drugs, as it has been mentioned. Treatment is by lowering the prolactin level using dopamine agonists such as bromocriptine or cabergoline. However, sometimes if there is no response or drug resistance, and there's a tumor, we can go to surgery. And if it is if it is drug induced, then we stop the causative agent. Here you can see pictures. Here is a pituitary microadenoma, a macroadenoma. Here, a craniopharyngioma involving the pituitary gland. If a woman with amenorrhea has hyperprolactinemia, the main symptoms are due to estrogen deficiency. We have to differentiate the hyperprolactinemia due to pituitary cause from those associated with PCOS. In cases of hyperprolactinemia per se, there will be no endometrial lining, so we cannot induce a cycle with progesterone agents only. We will need combined progesterone estrogen in order to build up the endometrium and then induce a withdrawal bleed, either by giving combined oral contraceptive pill, estrogen and progesterone, or giving estrogen at the beginning and progesterone later on in order to induce a withdrawal bleed. However, those with PCOS, they will have a high estrogen level. That's why they have a thick endometrium. So they will develop a withdrawal bleed in response to progesterone. And that's why it is necessary to induce a cycle at least every 3 months in patients with PCOS in order to avoid the risk of endometrial hyperplasia and endometrial cancer. Hypothalamic causes of secondary amenorrhea include craniopharyngiomas, primary, germinomas, gliomas, and dermoid cysts. Secondary could be due to other causes. These hypothalamic lesions either disrupt the normal pathway of the dopamine, causing hyperprolactinemia, or a destruction of the hypothalamic and pituitary tissue. Treatment is usually surgical with or without radiotherapy, and hormone replacement therapy is required. Systemic disorders causing secondary amenorrhea involve chronic diseases that could be due to the general disease state, the morbidity that the patient is passing through, losing weight, or the effect on the axis. For example, chronic renal failure, liver disease, endocrine disorders such as thyrotoxicosis and Cushing syndrome. Also, hypothyroidism, it affects the regularity of the menstrual cycle, so it has been corrected. Autoimmune endocrinopathies have been involved, and diabetes mellitus also. The patient's management should concentrate on treating the underlying disease and then preventing complications of estrogen deficiency. If fertility is the request of the patient, we have to achieve maximal health of the patient and then go to treatment treatment for conception. Weight-related amenorrhea, where a patient loses too much weight, for example, case of anorexia nervosa, she won't have menstrual cycles below a BMI of 19. Sometimes a patient may diet too much. She will have a severe diet, for example, before marriage in order to prepare herself for a new life. And she will find that her cycles have stopped after losing too much weight. There will be an impairment of the gonadotropin secretion. The management should be with a dietitian and psychiatrist at the same time if it is due to anorexia. If it's just due to a simple diet, we can just correct the weight with proper nutrition. An artificial cycle can be induced with a combined oral contraceptive pill. For example, as I mentioned, anorexia nervosa. Sometimes the starvation due to worldwide famines will result in delayed pubertal growth and menarche, where acute malnutrition affects fertility and ovulatory function, which is quickly restored with adequate nutrition. Exercise-related amenorrhea, which is found in patients who undergo extensive training, for example, gymnasts or patients who do gymnastics, the long-distance running, ballet dancers. Unfortunately, these patients will have a significant delay in puberty, retardation of pubertal development. They are at risk of menstrual irregularities and even fractures due to the hypoestrogenic state. A quick review of the causes of secondary amenorrhea. We have to exclude pregnancy. Then we think of the anatomical causes, the uterus and the cervix, Asherman syndrome, endometritis leading to Asherman's, cervical stenosis. We'll think of hypothalamic causes, tumors or functional hypothalamic amenorrhea, pituitary causes, ovarian from the polycystic ovary syndrome, ovarian tumors, premature ovarian insufficiency and hypothyroidism, and others such as congenital adrenal hyperplasia and adrenal tumors. Here is a list of the medications that can be involved or associated with amenorrhea. You can have a quick look of them. And a workup diagnosis. What is the workup plan? So we'll send the patient for a pregnancy test, serum LH, luteinizing hormone, follicle stimulating hormone, TSH, and prolactin levels, and ultrasound and other laboratory testings accordingly. If she's pregnant, we follow up her pregnancy and we exclude an ectopic. If the level of thyroid stimulating hormone is abnormal, we go for a thyroid function test and antibodies and treat. If the prolactin level is high, we will go to treatment or CT and MRI. If the uterus is present, then we ask ourselves through investigation by ultrasound. If there is no uterus, we go to karyotyping. If there is a uterus, it could be divided into low FSH and LH, normal FSH and LH, and elevated. Elevated, both of them means elevation of both of them means primary ovarian insufficiency. Both of them normal, we consider outflow tract obstruction, and low FSH, and we consider the causes of constitutional delay of puberty or primary gonadotrophin releasing hormone deficiency. Thank you very much for listening and follow up.